Well, thank you very much for the opportunity to speak today. My name is Deepa Jeyakumar. I'm assistant professor at UC Irvine. And a couple of disclosures. I am a Philadelphia native, so I have a lot of pride in any reference to Philadelphia. And I am an adult oncologist, so I'll do my best to review this amazing work in Philadephia-like ALL. The title of my talk is ALL Philadephia Negative, Philadephia Positive, and Philadephia-like. So I don't really have to review this for the entire the audience here, but in general, what is the Philadephia chromosome? Well, it was named after a city where the first described in leukemia cells in a CML patient with Knoll and Hungerford in 1960. And then 1973, Janet Rowley described the Philadephia chromosome was the reciprocal translocation of 922. And it's very appropriate that we're talking about this given that she recently passed. And then the BCR-ABL1 fusion gene is generated by joining BCR-ABL1 on chromosome 9 with the BCR gene on chromosome 22. And classically, the breakpoints of interest in CML are P210, P190 in ALL, and P230 also. So Philadephia chromosome positivity has long been described as being a high-risk feature in ALL in 4% of pediatric ALL cases and 25% of adult cases. And it's also been reproduced in multiple studies, the effects of BCR-ABL positivity on outcome. And based on the ECOG 2993 data, we know that the ability to achieve CR after first induction in pH-negative disease was 93% and 83% in pH-positive disease. Similarly, overall survivals are decreased from 41% in pH-negative disease to 25% in pH-positive disease. But we know now that the introduction of imatinib therapy in pH-positive disease has dramatically improved the outcome of these patients. And so previously, we understood that there were several subtypes of ALL: T-ALL, ETV, RUNX1, hyperdiploid, E2A rearranged MLL, and BCR-ABL positive disease. However, in 2009, Dan Bauer et al. Analyzed 107 newly diagnosed ALL patients and was able to find a cohort of 19% in the COALL data, as well as 15% in the GEP, in the Dutch group that had similar, unique phenotype, which was the GEP was similar to BCR-ABL positive disease, but the BCR-ABL testing was negative, and this was termed pH-like ALL. And he was able to go on to show that the survival of this group, both disease-free and overall survivals, were dramatically reduced compared to the pH-negative disease and closer to pH-positive disease. Similarly, they were able to show that there were genetic abnormalities, specifically in Icaros as well as PAX5, that again helped produce this genetic signature similar to the BCR-ABL disease. And another interesting point was that these cells were 73% more resistant to L-asparaginase, as well as 1.6 times more resistant to daunorubicin. And then Harvey et al., including Dr. Mulligan's work, have shown that in 207 out of 272 patients analyzed from the COG 9906 data had this gene expression profile, which was similar to the pH-positive disease. And then they were able to confirm this using samples from the 1961 trial. And they were able to show that this cluster 8 had worse relapse-free survival. And similarly, that they had a higher frequency of MRD positivity at the end of induction therapies at 81%, as well as self-reported Hispanic and Latino ethnicities at 50 to 60%. So this is led to the definition of PH-like ALL, which is found in about 15% of childhood progenitor ALLs that lack the Philadephia chromosome but have this gene expression profile similar to BCR-ABL positive disease. Frequently, it's associated with the Icaros deletion or mutation, and approximately 40% have mutations in this CRL2, and half have JAK2 mutations. Another interesting aspect of is the connection with the Hispanic patients of Hispanic origin. I think this story is it needs to be fleshed out a little bit more because it's not a direct correlation and more of an association where there's definitely a higher frequency of CRLF2 rearrangements found in patients of Hispanic origin, and frequently those are associated with this gene expression profile similar to of PH-like ALL. And there also seems to be inherited GATA3 risk alleles that have been described in a Nature Genetics review recently. So Lowe et al. Described 45 new patients, including 23 from this P9906 trial, as well as 22 patients from the ALL 0232 with this BCR-ABL-like disease. 68% of them were older than 10 years old. 62% had a white count greater than 50%. 64% were male, and 62 had MRD positive disease. And again, he was able to show that the event-free survival of these patients was inferior compared to patients with non-PH-like disease. In this study, they were able to show that it was 63% event-free survival versus the 85% in non-PH-like disease. And also, he was able to show that they're more likely to have MRD at the time of their initial induction, 63% versus 19%. So what about the experience of using TKI therapy in this group of patients? Well, there initially were several case reports that described using imatinib first in this setting. Weston described a patient who had relapsed EBF1 PDGFRB ALL who had residual disease and went on to achieve a remission treated with imatinib. And then similarly, there was also a description of a similar patient who had relapsed disease who was treated on Lenglin. By Lenglin with imatinib and was also able to achieve remission. So this led to a description of the outcomes of these PH-like ALLs that were treated with a risk-directed therapy based on MRD analysis during their induction. Among 422 patients treated on the total therapy 15 study between 2000 and 2007, they were able to identify 11.6% of them that had the BCR-ABL-like ALL. They were more likely to be male, more likely to have Down syndrome, and more likely to have high MRD levels at day 19 as well as at the end of induction. And 11 patients were found to have genetic rearrangements in CRLF2. And 27% were able to find the Icaros mutations. So according to the stratification, the low risk was 1 to 10 years old, with leukocyte counts less than 50,000, and high risk was 922 rearranged. Standard risk was based on T-cell ALL or B-ALL with 919 or other translocations. However, they did MRD analysis at day 19 that if it was positive with in the bone marrow of greater than 1%, or if at the end of induction they had greater than 1% residual leukemia, they were automatically risk stratified into the high risk category, whereas if they didn't have residual disease, they were able to continue on their standard arm. And so they were able to describe that these patients with the BCR-ABL-like phenotype were more likely to have MRD positivity, and this was statistically significant. However, what's interesting is that based on this risk stratification profile, they were able to have equivalent overall survivals and were able to be salvaged by treating them on a higher risk protocol. Similarly, there was actually no effect found on BCR-ABL-like status on overall or event-free survival when patients were treated according to this risk-directed therapy. I think this is an interesting article because it reflects the importance of assessment of MRD at the end of induction, but I think that the low percentage of Icaros positive in this population, as well as there's several other factors that may contribute to the lack of an effect, but clearly emphasizing the importance of MRD analysis at the end of induction and using that to risk stratify patients. So just a couple weeks ago, this same group was also able to describe targetable kinase activating lesions in PH-like ALL. They were able to analyze 1,725 samples in patients with precursor B-cell ALL. 330 were in children 1 to 9 with standard risk ALL. 853 of these children were high risk based on age and greater than a white count, 50,000. 374 were adolescents, and 168 patients were actually young adults, 21 to 39. And using this flow chart that enables us to screen patients because any patient who was found to have cytogenetic rearrangements was identified as not having PH-like disease. Similarly, patients who were able to find FISH gene rearrangements in the below noted were also excluded from this PH-like phenotype. And so then they were able to do a low density gene expression profile and identify these patients. And pretty impressively, I think they were able to describe that PH-like disease clearly increases with age. It goes from 12% all the way up to 27% as you age. And furthermore, they were able to identify these series of gene mutations that would be amenable to targeted therapies. So JAK2, the EPO, and the CRLF2 would be amenable to ruxolitinib inhibitor therapy, BCR-ABL1 to PDGFR, and CSF1R would be amenable to dasatinib. And then they did describe one case of NTRK3, which would be amenable to crizotinib. So within this study, they also described 12 patients who were treated on these monotherapies and the majority of them were treated based on MRD positivity at the end of their induction and were able to be salvaged and go on to remain in remission for several months. And impressively, they were also able to show the effects of event-free survival based on age and pH-like disease. It was 24% in event-free survival in going up to 58%. And similarly, they were able to describe in children, adolescents, and young adults the effects of overall survival. In children, 72%, 65% in adolescents, and 25% in young adults. And also impressively, they were able to describe the effects, the complex nature of the relationship with Icaros on pH-like disease, and you can see that in every stage of disease, the presence of Icaros, in addition to pH-like disease, affected the overall and event-free survivals. So in summary, pH-like ALL is frequently associated with poorer clinical outcomes to other B-cell ALLs and closer to pH-like ALL. Early identification of this subtype of ALL is key, and the incidence of this increases with the increasing age of the patient. And similarly, the survival of these patients is inversely correlated with their age. And the addition of targeted therapies to this subtype of disease and prospective clinical trials will be needed to study how this will improve the outcome of these patients. So, thank you.